Senator Runner.
Turn it around this way. Thank you, Madam President. I stand here as somebody who has a terminal illness. Actually, we all have a terminal illness. We know death and taxes are the only thing we can count on. We just don't know when and where. And I would have died without having a lung transplant. Did I want to do a lung transplant? No. Did I want them to find something that would make my lungs better and I could breathe? Yes. I remember a time in the hospital when I was in ICU for a couple months with intubated, couldn't talk, couldn't walk, and thinking, you know, maybe I'm better off if I decide not to live. Well, I happened to mention it one night. Of course, I was heavily drugged to one of the nurses, which then she told somebody who told my doctor, who told a psychiatrist to come and visit me. So it got more than it was supposed to be. I had no intention of doing that. But even the struggle afterwards, I think there was not a time that I didn't think, you know, it's not worth it. It's not worth staying alive in the struggle. The first year with the medications, in the hospital again. But you know, if I didn't do that, I wouldn't be here today. I wouldn't be able to see my latest grandson that was born since I had my transplant. I wouldn't be able to serve the body and the constituents of my district and care for the people that I represent. So there's oftentimes, you're not making good decisions when you're in pain, especially when you're medicated. So if that person makes a decision and may regret it, you know, the next day, are we all of a sudden gonna give them the prescription, give them the shot, and they're gone, and they didn't have an opportunity to say, you know, I've reconsidered that, because many a time during that 2 months in ICU, I considered it and didn't do it. But look at the life I have now and continue to live and serve and play with my grandchildren. It wouldn't be possible if I had decided to do that. So thank you very much.
Senator Gaines.
Thank you, Madam President and members. Permission to read?
Without objection.
And this is an article by Dr. Carity, Director of the Program in Medical Ethics at the University of California, Irvine School of Medicine. And there's a couple of points I'd just like to bring up here. In the last 20 years, more than 100 campaigns to legalize assisted suicide have been introduced in various states. All but 3 have failed. In 2012, the same Massachusetts voters who elected Elizabeth Warren and re-elected Barack Obama gave the thumbs down to doctor-assisted suicide. One more point. The suicide rates in Oregon rose dramatically in the years following the legalization of assisted suicide there in 1997. After declining in the 1990s, rates rose between 2000 and 2010, surpassing the rate of increase nationally. As of 2010, suicide rates were 35% higher in Oregon than the national average. If I could return to my comments. I rise in opposition to this bill. The Declaration of Independence, this country's founding document, states that all men are created equal, that they are endowed by their Creator with certain unalienable rights, that among these is life, liberty, and the pursuit of happiness, that to secure these rights, governments are instituted among men. This government, where we serve the people, is a bulwark for protecting the lives of the innocent. It is a total inversion of its purpose to transform it into an instrument of death. It's an abandonment of our duty to usher in a regime that is in direct opposition to the Constitution we've sworn to uphold. The original Hippocratic Oath states, I will neither give a deadly drug to anybody who asks for it, nor will I make a suggestion to its effect. What is being proposed in this bill is a clear and unflattering contradiction to the life-affirming ethics that are as old as the medical profession itself. As a society, we fight for life desperately in premature births, in accidents, for which my wife suffered one and was pronounced dead at the scene, and they were able to resuscitate her. Through the societal costs of sharing the extraordinarily expensive drugs that can heal or stretch out the life of an individual for even a few months, our cultural attitude toward life would suffer a fundamental shift under this bill, greatly for the worse, if we stop fighting for life in these situations. Will we fight so hard when we have an infant struggling to begin life's journey? Will we shrug our shoulders and throw in the towel, as this bill effectively does for the ill? And examples of so-called terminally ill recovering and going on to live for years and even decades are many, as spoken by our colleague. I had an incident with my father-in-law who got a very serious infection, and we were certain he was going to die. And we were starting to make arrangements as to how to handle that. And we had this debate as to what do you do in this situation. And he recovered, and that was several years ago. And he spent so many days with our children and with his other grandchildren. And we're just so grateful of his recovery. It may also be that those who are ill are demoralized by their conditions, depressed or lacking hope. In every other circumstance, we would regard those symptoms as passing and would view someone taking their lives because of them as a grave tragedy that we failed to prevent. That is a call for counseling, for faith, not suicide. Doctors should kill disease. They should kill pain, but they should not kill their patients. It doesn't matter if we call it death with dignity or compassionate choice, or anything else. The name is of no consequence compared to the act, the affront to our history, or the precedent of our future. I urge a no vote.
Senator Stone.
Thank you, Madam President. I first want to commend the Senate authors for their genuine concern to minimize patient pain and suffering. However, I must rise today and stress that I have many grave concerns, no pun intended, about this bill. Physicians take a Hippocratic oath, which we are effectively asking them to abandon. Here is a passage from that oath. With regard to healing the sick, I will devise and order for them the best diet, according to my judgment and means, and I will take care that they suffer no hurt or damage, nor shall any man's entreaty prevail upon me to administer poison to anyone, neither will I counsel any man to do so. As a pharmacist, I am party to this very important oath. Physicians' diagnoses aren't always right. Sometimes they're wrong. And I believe this bill could have a dramatic effect on the poor in this state. Could the poor, minorities, and uneducated citizens be more vulnerable to abuse and errors and may not have the access to a second opinion or a third opinion afforded to more affluent people? And as a result, we may see in the future a much higher incidence of physician-assisted suicides among those that we care the most about. Is this an equal protection under the law issue? Patient suffering can and continue to be mitigated with palliative care. Not only am I a pharmacist, I'm a compounding pharmacist, and I compound the world's strongest analgesics known to man, and it is a specialty of mine. I deal with pain centers throughout this state. I deal with pain centers throughout this country. I've taught pharmacology about pain control to graduate nursing students. I know how the drugs work, and I know how they ameliorate pain. Some examples. The mainstay for treating somebody that is on hospice is morphine. We have other drugs in our armamentarium, Dilaudid, 7 times stronger than morphine. Fentanyl, 100 times stronger than morphine. Sufentanil, 1,000 times stronger than morphine. I can tell you that through my involvement in hospice, that we are able to ameliorate significantly one's suffering. I'm just going to touch upon some religious issues, and my good colleague from Los Angeles said we shouldn't allow those institutions to dictate what we do on this floor. But I personally believe, as a man of faith, that one day we will be judged by what we do on this planet. Catholics believe that any death that is not a natural death, that may be brought on by any outside influence, specifically intended to shorten life, is a sin. They believe that Scripture specifically denies any form of self-infliction of death or assisting another person's death, no matter what the circumstances are. Mormons are vehemently against suicide. Presbyterians and Lutherans are firmly against it. Southern Baptists feel it violates the sanctity of life. And for the most part, my own religion, in consulting with my own rabbi, the Jewish religion is against the choice of aiding in dying. The Islam religion strictly forbids any form of assisted dying because, according to the Quran, all life is worth living. There are some that have argued that there is a financial incentive to have sick people facing high medical costs to save money by choosing cheap drugs that can end their lives. But the cost of care should never, my friends, should never be a factor in the right to die arguments. You cannot equate money with human life. Taking one's life forecloses any chance of a miracle or a possible recovery. One of the authors who spoke today talked about neuroblastoma, a horrific disease. It's the cancer of the brain where tumors double in size every single week. And because those tumors in the brain that govern our neurological systems causes significant pain and suffering. There was a case here in the state of California that I believe instigated this legislation. It was a young lady that had neuroblastoma. She chose to go to one of the states that allows for assisted suicide. She had this horrific fear of suffering, and she justifiably had those fears. But we are on the cutting edge in medical science. There is a new treatment now where you inject the polio virus into a neuroblastoma tumor. Maybe many of you saw the 60-minute special on this about a month ago. And what was considered 100% fatal had patients living because that polio virus elicited such an immune response by the body, those tumors shrink. The patients are healed. It's unfortunate that we could not make that treatment available to this young lady. Let me tell you about Jeanette Hall of Oregon, who was diagnosed with cancer in 2000 and was told she had 6 months to live. She knew about assisted suicide, and she asked her doctor about it because, justifiably so, she did not want to suffer. Her doctor encouraged her not to give up, and she decided to fight the disease. She underwent chemotherapy and radiation, and 11 years later she wrote, "I am so happy to be alive. I would be dead. Assisted suicide should not be legal." Unfortunately, not all doctors are like Jeanette Hall's. Many of our elderly parents and grandparents also may not have the mental capacity to make such a decision, but greedy heirs can have an influence. And I know there are some safeguards, but I want to talk about some of those safeguards and how I think they're not foolproof. And we'll get to that in a moment. Again, this bill may eliminate palliative care. Euthanasia has been legal in the Netherlands since 2002, and experts say that this is the reason that there is very little palliative care available there. If the right to die becomes prevalent in the United States, then palliative care will no longer be a high priority or maybe even de-emphasized. Studies show that hospice-type palliative care is virtually unknown today in Netherlands. There are very few hospice facilities in Netherlands, very little in the way of organized hospice activity, and very few specialists anymore in palliative care. Another issue is doctor shopping. I want to give you a real-life example. Casey, who was 85 years old, died by assisted suicide under Oregon's law, even though she had early dementia. Her physician had declined to provide her with the lethal prescription. The second physician ordered a psychiatric evaluation which found that the patient lacked the very high level of capacity required to weigh options about assisted suicide. The patient's request was denied, and her daughter became angry and referred her to another psychologist in meeting her mother. Disturbingly, the psychologist deemed the patient competent while still noting that her choices may be influenced by her family's wishes and her daughter, which may be somewhat coercive. Her managed care provider then found another physician to prescribe the lethal dose. This 85-year-old patient soon took the drugs and died. So how would the provisions of this law work here? The bill would make it a felony to knowingly coerce or exert undue influence on an individual to request a drug for the purpose of ending his or her life, or to destroy a withdrawal or rescission of a request. If it's just the patient and a child that know about this coercion, how is this crime ever going to be exposed? The bill further says that mental health specialist assessment means one or more consultations between an individual and a mental health specialist for the purposes of determining that that individual has the capacity to make medical decisions and is not suffering from impaired judgment due to a mental disorder. My friends, the daughter that I mentioned before shopped around until she got the report she wished, enabling her mother's physician-assisted suicide. Further, this bill, if you read it, requires two witnesses that the patient is requesting physician-assisted suicide, yet one of those witnesses can be a blood relative and heir to the deceased's estate. Do we really believe Casey's daughter would not have been a witness? And do we really believe that money could not buy a second witness? How about malpractice cases? There are malpractice cases from California to New York. And what happens during a surgery if it doesn't go well? A physician goes to a family and says, you know, your mother, your father, your grandparent didn't do well in the surgery, maybe covering up a malpractice issue that might have happened that was irreversible, and urges that child, urges the husband to go for an assisted suicide. Our broken system of health care, some cases again in Oregon. Barbara Wagner underscores the danger of legalizing assisted suicide in the context of our United States healthcare system. Ms. Wagner, a 64-year-old great-grandmother, had recurring lung cancer. Her physician prescribed a drug called Qarziva to extend her life. Studies show the drug provides a 30% increased survival rate for patients with advanced lung cancer, and patients' one-year survival rate increased by more than 45%. The cost of the drug, $7,000 a month. The Oregon Health Plan sent Ms. Wagner a letter saying the plan would not cover the beneficial chemotherapy, but it would cover the physician-to-suicide meds. Protocols. The state of California can't even agree on a perfect lethal injection formula for our capital punishments cases. Do we really believe, my friends, that this is going to be any easier? The mainstay of killing through physician-assisted suicide is a drug called pentobarbital. For those of you that remember the 60s and 70s, we commonly call them yellow jackets. How does this drug work? When you give this high dose of a barbiturate, it works by suffocating those victims. And we all know that it takes 6 to 7 minutes for the brain to be without oxygen for death to occur. Who knows how much suffering goes on with this high-dose barbiturates? No one has ever come back to tell us. But let me tell you this, and this is from the literature, that barbiturates have little analgesic action, which means they don't reduce pain, and at sub-anesthetic doses, they actually increase the reaction to painful stimuli. So the drug that is classically used to kill patients can actually increase their stimuli to pain, although they cannot express it because they're in an unconscious state. Protocols for assisted suicide may not cause a quick death, which is the motivation for many people using these protocols. Assisted suicide proponents and medical personnel alike have established that taking lethal drugs by mouth is often ineffective in causing a quick and simple death. The body sometimes simply expels the drugs through vomiting, or the person falls into a lengthy state of consciousness rather than dying promptly, as assisted suicide advocates wish. Such ineffective suicide attempts happen in a substantial percentage in Oregon. They estimate that 15% to 25% don't die immediately. With access to minimal data available, we know that there are serious problems occurring related to assisted suicide protocols. In 2009 in Oregon, it took one person 4 days, 8 hours, 104 hours total to die after ingesting lethal doses of drug. In 2013 in Washington, it took 1 day, 17 hours for an individual to die after ingesting a lethal dose of drugs. These are just two of many examples where it took over 90 minutes for a person to die. My friends, in executions, if it takes more than 60 minutes for a person to die after being injected with a legal dose of drugs, it draws considerable controversy related to cruel and unusual punishment. Burden to family. According to prescribing doctors, 40% of people who die by assisted suicide report feeling like a burden on family and caregivers is a reason for requesting lethal drugs. What a shame. What a shame that one would yield to such undue pressure. And now, Madam President, I'm just going to summarize very quickly. Again, the authors, who I have a tremendous amount of respect for, and all of my colleagues, irrespective of where this goes today, I feel honored to be a part of this body on this red carpet in a democracy where we can debate such important issues that deal with life and, yes, death. I have spent 34 years of my life as a practicing pharmacist, owning and operating 6 pharmacies, a compounding pharmacy that is one of the most successful, maybe in the state, maybe in the country, that specializes in making sure that people don't suffer. And I can tell you, we succeed in minimizing patient suffering. And yes, through hospices, we hasten one's passing naturally. Palliative care works and has been proven to minimize patient suffering. With advanced technology, new treatments, and drugs that can appear at any time, why not hold hope? Why not take the chance that there could be the silver bullet out there that could save somebody's life? Existing laws of physician suicide have flaws, And I really believe that lower income people, less educated people, will see physician suicide as their only alternatives when others exist. With my son as a deputy district attorney in Riverside County and working in the elder abuse unit, I have heard horror stories about what impatient relatives will do, including attempted murder to inherit their loved ones' estates. In one case, there was a daughter who had a mother that was a paraplegic, that lived with her mother, was impatient, and she wanted her mother's estate. She moved her mother out in a wheelchair outside in the ambient temperatures of 105 degrees a day, went to work with the hopes that she'd find her mother dead in the backyard, but a neighbor saw the unconscious woman, called 911. The mother was saved. My son was the prosecutor and put away this daughter for attempted murder of her mother because she wanted her estate. With people living longer, a law like this is ripe for abuse. Another thing that I've heard about is death tourism, going to the states that authorize this physician-assisted suicide. What is going to be the new theme of the state of California? Come, play, live, and die in California. And lastly, as I mentioned before, I am party to the Hippocratic Oath that has governed my full attention to the aid in healing and helping people cope with diseases and the often painful sequelae of those diseases. And finally, my friends, I believe God giveth life, and it should be only God that taketh life. And for these reasons, I respectfully ask for your no vote.
Senator Mitchell.
Thank you very much, Madam President. Colleagues, let me start out by saying I will be brief, and I am going to try not to lecture you. We all have personal stories, all of us. Some on the floor here have actually taken the Hippocratic Oath. We all have our own life experiences. We all believe fundamentally that our children and our families would not perceive us as a burden. They would step up and do the right thing. We have a colleague here who's been generous enough to share her personal health stories, and today even talked about a very difficult time in her life and her family's life when she felt like she was at the end of her rope. My own mother, because I have a story like all of you, said to me, I don't want to be a burden. But I fundamentally understood when she said she didn't want to be a burden what she was also saying to me. She was also saying to me that she intended to have full control and make decisions about her life, that she intended to have a choice. She intended to have a choice. My colleague said that she made a particular decision, that she was going to get through it. Should her choice impact or limit my ability to make a choice about me? It's an issue of personal choice. This bill is not a mandate. It empowers us as legislators to give the 30+ million residents of the state of California a choice, a personal choice that they can make. This is not a matter of public health. This is a matter of personal choice. And so while we certainly believe our families would make the right decisions, we also seem to be really fixated on those children who are out to benefit on their parents' death, or those who don't have the capacity to make a decision about their own lives. Well, we cannot legislate morality. So how do we stay in our appropriate lanes as policymakers to design a body of laws that are appropriate for a state as expansive and diverse as the state of California? We can and have repeatedly crafted laws that include sufficient protections and safeguards. Protections under state law regarding of sound mind and without coercion, numerous sections of existing California code. The W&I code under adoptions gives the birth parent time and right to make sure that they're making a decision with sound mind and without coercion. We have the capacity as public servants, as lawmakers, to design laws that create protections so the least among us are not taken advantage of. As a part of all personal stories, all of us have our own life experience. In a state with 30 million people, we could have 30 million stories we could all stand here on the floor and read to both support and oppose what this bill would allow. We could be here all week reading story after story, citing example after example. But what we as policymakers have a responsibility to do is to craft a body of law that gives access and supports the personal choice and the individual rights of the residents of this state. Again, this bill is not a mandate. This bill will not force me, if it is not my religious, cultural, ethical belief, to do this. It gives me the right and gives me access to make a personal choice if I so choose. And for those reasons, I'll be supporting SB 128.
Senator Anderson.